Greetings. Welcome to the first class in the third semester of the Emerald Choral Academy. That's very exciting for us, our third semester. I am Gary Cannon, the artistic director of the Emerald Ensemble, a professional choir based in Seattle. This Emerald Choral Academy is a series of interactive webinars during which our area's leading professional choristers reveal their personal tricks of the trade to community singers. These webinars are then made freely available to singers across the world via YouTube. This presentation is funded in part by a grant from the Washington State Arts Commission, in addition to funding from the National Endowment of the Arts, For Culture, the Seattle Office of Arts and Culture, and many generous donors. We encourage anyone participating or viewing this webinar to make a donation as you are able at emeraldensemble.org. You can also subscribe to our YouTube channel and join our mailing list to hear about future sessions of the Academy and the other activities of the Emerald Ensemble. This webinar is being recorded. By participating, you are granting the Emerald Ensemble permission to share your contribution. Your microphones and cameras will remain off for the duration of the presentation. You can, however, ask questions to the presenter by typing into the chat or the Q&A features at the bottom of your screen. And then periodically, I'll interject to field your questions on your behalf. Today, the Emerald Ensemble is very excited to welcome back baritone Ryan Bede into our musical family. Ryan is deeply beloved by Pacific Northwest opera audiences. Very recently, he moved to Central Tennessee. So this is our first multi-time zone session of the Choral Academy. When Ryan was here, he taught at Seattle Pacific University and Tacoma Community College, and he still teaches at Pierce College. I've sung with Ryan, I've conducted him, always such a charm and a pleasure to work with, and truly a consummate musician. Ryan's topic today is Vocal Anatomy 103, the larynx. It's a pleasure to introduce to you my colleague, Ryan Bede.
Good morning. Thank you, Scott. Thank you, Gary, and thank you to everyone who is assembled here today to take in this presentation, Vocal Academy 103, based on the larynx. I know in recent Emerald Choral Academy presentations that other presenters have addressed some of the other fundamental topics pertaining to the vocal process, and being that the larynx is quite a remarkable structure that is responsible for so much of what we do as singers, it's fitting that it gets its own presentation. So I'm going to now share my screen so I can share my PowerPoint with you all. Hopefully this will be very seamless. Be able to go for this. Moment while I ready to present. I'm sorry for the delay. Taking me just a moment. Here we go. All right. Okay, Vocal Academy 103, the larynx. I decided to begin today with a short review of what we call the 5 systems of the human voice. Your first few presentations in the vocal anatomy vein were pertaining mostly to respiratory process, if I'm not mistaken, and some of the other baseline fundamental things that make up how we produce vocal tone. I made phonation bold today because that's the main system that we're dealing with pertaining to the larynx. So just as a small refresher, the respiratory system, which consists mainly of the lungs, trachea, bronchi and all of the associated branches and things like this, and how the air makes its way from its genesis in the lungs out through the larynx and eventually out our mouth to produce the tone that we sing. You also have no doubt heard about the musculature and associated processes that deal with respiration, the muscles that are found in the thorax and in the trunk and abdomen that aid in our beginning of the vocal process. Phonation is the actual creation of the sound. And that's what we will be discussing today, because that in fact happens at the larynx. Obviously, much more to be said about that. So let me just move on for a moment and just briefly explain these remaining three terms. Registration, for those of us who may be encountering that term as pertaining to the voice for the first time, deals basically with those terms like chest voice and head voice. High in the male voice, we find the register known as falsetto. We also have maybe heard about vocal fry, which is the mode 0. They've now assigned mode 0 to vocal fry, mode 1 to chest or modal voice, mode 2 to head voice, falsetto, and associated things, and mode 3 to the flageolet or whistle voice found chiefly in soprano persuasion of voice. So registration, essentially in a nutshell, we're talking about chest voice versus head voice. And as we will discover during this lecture, the muscles that are in charge in various registers of the voice are large designators for that. When we talk about resonance, as I'm relatively sure a future presentation will be delving into, we're basically talking about the space between the vocal folds and the pharynx. So we have, argument can definitely be made that it also is including the mouth, because, mouth, the shape on the inside of the mouth can pertain greatly to resonance. But basically we're talking about the shape of the tract from the larynx through the oro and nasopharynx. And then the final phase or system of the human voice is articulation. Your lips, your tongue, your teeth, your soft palate. In certain cases, in certain languages, namely French, for example, the nasal cavity plays a role. These 5 systems are independent, but they're also interdependent. They rely on each other to work in harmony, I suppose, pun intended, to create the full vocal process. This is your first look at a picture of the larynx and vocal folds, which there will be many other illustrations as we move forward. I do hope my illustrations are large enough for you to see. If there's anything that you want to be explained, please put that in the chat or in the Q&A and we can happily go back. Onward we go. I titled this slide, Your Larynx, More Than Just a Voice Box. The larynx is also known as the voice box. It is the structure where spoken and sung tone is created, but it has so much more intricate a task and purpose than just creating voice. Every musical instrument, whether it be a trumpet, a clarinet, a violin, a guitar, a piano, anything that we consider a musical instrument. I often make the analogy to my students that our voice, being an instrument that lives inside our body, is one of the only instruments that you can't just take away from your face or put down at the end of the day and put it in its box or however it's stored. I suppose you can't very easily move a piano either, but in any case, we are the only instrument that we carry within our body. And as I think I mentioned that several times when I was fortunate enough to lecture on some vocal health topics before, we have to take care of our body to take care of this instrument that lives within it. So every musical instrument requires the following: requires some sort of power source, requires something that vibrates, and requires something that resonates. Now, there are more things that some instruments have that others don't, but these are really the requirements. So as a former trumpet player, as one of my other singing colleagues who is also a former trumpet player often calls herself a recovered trumpet player, I'll use the analogy of the trumpet as the instrument, the non-voice instrument for this purpose. So the power source for the trumpet is no different than the power source for the voice. That is, in fact, air from the lungs. Think about a person playing the trumpet that the inspiratory phase happens, the expiratory phase begins, and that air heads towards the lips, which buzz as the vibrator, the things that vibrate or oscillate to create some sort of tone. And I'll just do for the first time now something that will come back when we're talking about pitch and how it's changed. Notice that I can change the sound of that buzz. Based on the tightness of the lips, the type of air, the speed of the air, the intensity of the air, and the amount of air. These are all things that have a really heavy bearing on tone when it comes to singing too. So the lips vibrate, and then the resonator is in fact the trumpet itself. That tone that starts out as just a buzz, and if you listen to a audio recording or a video recording, there are many available on YouTube of just sort of, for lack of a better term, raw vocal sound. It's very buzzy. It doesn't sound anything like a wonderfully produced operatic tone or a bright, forward, thrilling high music theater belt tone. It just sounds very, very buzzy, okay? Without the resonating cavity that we have in our voice, the tone does not develop. Without that trumpet to develop the resonation and resonance, the sound is just that buzz. We, however, have a unique advantage with our voice, and that's one of language. When it comes to the way that music is articulated, I'm sure all of us have been in experience with terms like staccato and legato and other things that tell us how to play the notes or how to sing the notes. But we have the unique advantage of using language, using words to articulate the sound. And the last phase of the vocal process is in fact articulation, where we use various structures within the mouth to modify that sound from a resonant raw vowel, to put it that way, into actual text. Now, laryngeal sound is in fact a bit of a coincidence, and a fortunate one, because the larynx's main jobs are really not primarily to produce sound. Really, the primary job of the larynx is to be a valve. Now, it's a valve that's very akin to the valves that go in and out of the stomach. You think about all kinds of other places in the body where there's a bit of a gateway. We don't want things from the stomach coming up into the esophagus. We don't want things from the esophagus, getting down to the stomach if we don't want them to. There's all sorts of other places in the body where valves are found. Large ones in the heart will be very familiar to lots of us. But ultimately, the job of the larynx is to protect the airway. The vocal folds lead down into the trachea, which leads down into the lungs, and we don't want anything going down into that area. That's a quite unfortunate process known as aspiration, which is not a good situation. So the larynx and the epiglottis, which is a cover that comes down over the top of the vocal folds and prevents entrance of foreign objects into the trachea. These all work together as this sort of protector of the airway. But the larynx also allows us to create a situation of increased pressure. Think about a weightlifter, lifting a heavy weight. Now, as a singer who also enjoys lots of physical and sports pursuits, this has to come with a bit of a caveat, because when we're doing things in athletics that would, where the action might benefit from a bit more pressure inside, we have to make sure that doesn't adversely affect the voice through holding at the larynx. But just think about situations like weightlifting or childbirth, or several other functions that the body needs to do for where we need increased, essentially, intrathorax to perhaps use a term I hope correctly, intrathoracic pressure, we'll just say, um, is the second sort of facet of the larynx's main job. However, it also is capable of creating the sound, these waves of interruption of the air that our ears hear as sound. Now, the larynx itself is quite small, but incredibly important, small but mighty. I want us to take a moment here, and I really will assure you that this is something that you should feel very free to do to your own anatomy here in your neck. You're not going to hurt your larynx by some light palpation. I just want you to take a moment and become aware of this structure that is in your neck. You know, if you're one who has a prominent Adam's apple, that's a really easy way to find the upper prominence of the larynx, as will be, excuse me for turning it the wrong way, that would be associated with this bump right here. But just take a moment and just feel how relatively small that structure is. The average human male larynx is about the size of a walnut, and the average human female larynx is about 40% smaller, or roughly the size of a pecan. Obviously now, we know that there could be some necessary discourse and dialogue pertaining to different, how, a larynx in an individual, perhaps born in one, in one situation, transition to another. That's probably for another day, but it's for that's a very worthy area of research that is being pursued and really actively followed by some incredibly intelligent minds right now. So I look forward to the evolution of current research into the way that we train trans voices, and how we might change our pedagogical application pertaining to individual identity. On we go. We have an opportunity to meet a number of structures here in the larynx that all end with oid. We have thyroid, cricoid, and arytenoid cartilages in the structure of the larynx. You'll also notice that this particular diagram, which I'm grateful to teachmeanatomy.info for providing, also mentions the corniculate cartilages. I'm not going to focus on these heavily. They're located here. If you can see my pointer, basically we're talking about this, this area right here is the thyroid cartilage. We'll be going more into this in just a few moments. This is the cricoid cartilage, and around the back of the structure of the larynx, we have a pair of arytenoid cartilages, the only cartilages in this structure that are paired with each other. The green structure here is the epiglottis that comes down over the top of the vocal process to prevent foreign objects going down, as we've said. So I am also pleased to introduce you to Luther the larynx. I have several teaching and singing colleagues that have larynx models that they use, and they all seem to have come up with really witty names for their larynx model, and I'm a proud Lutheran boy, so I figured that mine should be named Luther. Well, here we have the cross section. If we're looking at a lateral view, at the side view, right? We're looking at the prominence of the Adam's apple right here, the tip of the thyroid cartilage. That this picture is a bit confusing. It's this ridge right here. You can see a little bit that it is protruding, but it definitely protrudes. And then when we get down into this area right here, we're looking at the cricoid cartilage. Okay, and then this is the beginning of the trachea here, a paired, a series of sort of interconnected rings that form the windpipe. Now, in between each structure, between the thyroid cartilage and the cricoid cartilage, we have a bit of I hope it isn't too hard to see, we have a bit of a membrane here. Now, we'll need to get accustomed to calling things by the names of either things they connect, or in a muscle's case, where it originates and where it enters, where it connects on the other side. So as you might guess, here we have a cricothyroid membrane. There's also membranes that we need to attach the cricoid cartilage to the arytenoid cartilage, and those words are combined as cricoarytenoid. We'll also hear the term thyroarytenoid and cricothyroid, as I said a second ago, over the course of the next hour or so. But it's of note that thyroid actually means resembling a shield. Okay, so anything oid means resembling or like. Okay, so like a shield is what we have when we are coming into the thyroid cartilage. I'm just going to take a brief detour for a moment, bring Luther back here, and talk for a second about this structure right here, this white structure. I hope the color crosses over okay in the computer screen here. This is in fact the hyoid bone, the hyoid bone. And the hyoid bone is located above the larynx. So now we're going to go back to some hands-on here. I hope it's okay in the next hour or so. I'm going to ask you to do this a few times. I want you to go back to palpating the superior, the upper side of your larynx, okay? And just find that prominence at the front and just run your finger up a little bit. And there's a ridge there, and you'll find a fairly stiff prominence there. The hyoid bone is there, okay? The whole larynx is suspended from the hyoid bone in a connection that is made only of muscles, ligaments, and other membranes, not bone to bone. The hyoid bone itself is also not connected via a bone-to-bone connection. So there's lots of ability to move and to rock and to shift, and we're grateful for all of this when it comes to singing. Researchers have revealed to us that the way that the larynx evolved into something that can tilt and change position is really very important for the evolution of our language and the way that we communicate. So it's a wishbone shaped bone. This is looking at the one half of the larynx. If I were to put them together, you would see the sort of wishbone. You get an early look down the through the vocal folds, if you can see in the light there. But the hyoid bone as a whole is wishbone shaped. It also is the attachment point for the tongue. Okay, we have muscles that help our jaw to open and close, to go side to side. Think about chewing and things like that. And also we have a interaction between the tongue, the hyoid bone, the larynx that gives us the ability to swallow. Okay, so this brings in the idea that any sort of undue tension or bad posture through this area could really adversely affect our singing, because the hyoid bone is connected to the larynx, right? And all these sort of things, because they are interconnected, it doesn't mean that they all go the same direction all the time, but they are going to influence each other. So jaw tension and tongue tension, we're not talking about vocal difficulties or pathologies so much today, but let's just take a few moments and talk about the ways that we can liberate our jaw and tongue a little bit. I'm sure that these things will be sort of expanded upon in future lectures, but because of its extreme importance, I just wanted to take a moment. So a few things I can recommend to you are, number one, just to take your thumb and very lightly massage underneath the point of the front of your jaw. The tongue root is found down here, like we said, right at the hyoid bone. If you're talking while you do this, like I am, you'll notice how much the tongue moves around while you're talking. And there's obviously lots of things that we can do to, make that motion more efficient for singing. So a base or root of the tongue, slight is a great thing to do as the beginning of your vocal routine. Also some tongue stretches. Think about bringing your tongue straight out a little, maybe a little further than you're used to bringing it out, right? We're told for, our young years that sticking your tongue out is not very polite. Well, I'm giving you your permission for right now to stretch your tongue out a little bit. Be aware of the ability to relax it and allow it to really flatten out and become kind of fat and not too tense, okay? Now I'll suggest that you take the tip of your tongue, put it behind your top teeth, and kind of flex the middle of your tongue out. Now, I'm going through these quickly, but you can also take the tip of your tongue, place it behind your bottom teeth, and move the middle of the tongue out, okay? Now imagine that your tongue was a toothbrush and you're going around the surface of your teeth with your tongue. You do this in a mirror, you can see how much jaw movement can get involved in this, so don't do an extreme chew while you do this. But speaking of the jaw, we have some muscles that are right up here called the temporalis muscles. So I really like to give myself a bit of a self-massage here. That way you can really modulate how much pressure you're putting on. Certainly shouldn't hurt, but we should know they're there, okay? We also have a muscle that's a muscle of chewing called the masseter muscle, okay? So right below your cheekbones right here, you can open your mouth and hold it open an inch or two, and kind of become aware of any sort of tensions that are going in there. You have some other muscles that are only easily accessible from inside, which at such a time we are right now, I've been for a long time now discouraging putting one's hands inside your mouth, but the pterygoid muscles that are found inside, their axis is found inside, is another place that you can do some self-massage. Okay, so I think, Gary and Scott, we were going to take a moment here and pause for questions, if there are any questions thus far.
I don't see any questions coming up. No, thank you very much, even for this. I'm learning so much. I'm taking so many notes.
Oh, good.
And now I feel so relaxed.
Oh, good. I'm so glad. I mean, the idea that we're about to use a lot of muscles and about to use a lot of structures when we're going to sing. Not unlike any athletic pursuit, we do well to liberate and stretch them out and get them free. Just sort of while we're stopped, I'll probably call back to this, but I think you can still see me reaching into my neck here. We talked about the hyoid bone, and we've talked a little bit about the thyroid cartilage. You can actually put a finger and your thumb in what we call the thyrohyoid gap. While we're stopped, everybody just do that. You can kind of actually move your larynx side to side a little bit. And if you do it when you're not talking, it's even more easy to do. Just be aware of how mobile that structure is and how much access we have to really liberate and stretch out some of those muscles.
I do like the notion too that you're encouraging now we're all sitting in our respective homes sticking our tongues out in different ways.
That's right, and I didn't mention it, but it wasn't lost on me that you all have your cameras and microphones off, so you really have no excuse not to try these things. I'm the only one who has to try them in front of you. So fortunately for me, I've done them and I've watched myself do them on camera, and I've gone through my period of uncomfortability with watching that, and I brushed my teeth, so everything's good.
I'm still seeing questions, so I'll add maybe just one last comment, which is,
please,
I think, regarding singer etiquette.
Oh, sure.
And that is, for decades now, whenever I see an instrumentalist who's about to walk through a doorway, I will hold the door open for them. And usually they'll say, no, it's all right, it's all right. I say, no, your instrument is larger than mine. And I'll, point to this little thing. And then I finally realized that was not the case, because my whole, corpus is my instrument. So now it's just nice. But if you'd like to do a favor for an instrumentalist, you can humbly acknowledge the importance of your larynx in your instrument.
Yes, absolutely. That's great. Yeah, I think about, I think about a string bass player walking through the door as you're making that analogy, and the string bass, I guess, may be taller than some of us, but in most cases,
that
we
was
do
that.
have a larger instrument than
Yeah,
most do.
that was actually the epiphany, is when I was holding the door open for a string bass, and I realized, wait a minute, this one actually is larger. That wait, this my whole world shifted. So
Yep.
anyway, now it's just kind of all right. Yes, I'd say let's go ahead and proceed then. Thank you.
Wonderful, wonderful. Onward we go. We're going to talk about the actual structures that we find in the larynx here, and I'm going to talk about them first, and then I'm going to show you some actual manipulatives with this. So, as we said before, there are three main cartilage parts. There are some others that are less um, obvious. I won't say they're less significant because, like we said, independent and interdependent are important terms to keep in mind. So the thyroid is the largest cartilage in the larynx. Okay, the largest cartilage in the larynx. We have the thyroid right here, coming down between below the hyoid bone. Okay, not to be confused with the thyroid gland, which is actually part of the endocrine system, responsible for hormone production and all of these sort of things. And it does bear mentioning that if any of us ever have a situation where we have a particular issue or pathology with the thyroid gland, that it's especially encouraged to share with your physician or surgeon, if it comes to that, that you are either a professional or an avocational voice user, but you care about the sounds that are coming out of your mouth a particular lot, and that care should be taken in the thyroid gland area. At the top of the thyroid, this Luther shows it really well. There's a notch here. Okay, we'll say just a quick anatomical term refresher here that we have superior towards the top, inferior towards the bottom. Okay, medial is towards the middle, lateral is towards the side. Okay, so we have an anterior front and posterior rear. So at the anterior superior point of the thyroid cartilage, we have a notch. And right below this, it's difficult to actually feel this, but you can put your finger on the prominence of your thyroid cartilage. And just as you go down, I'm just going to estimate maybe about a finger's width. So much of this is dependent upon individual anatomy that it's really not possible to make a blanket statement. The anterior commissure is the name of the place where the anterior attachment of the vocal folds happens. So that's just something to know. Okay. The cricoid cartilage is next down. Okay, we have below the thyroid, we have a bit of a membrane, which quiz time, that would be cricothyroid membrane. Okay, then we have the cricoid cartilage, which is the only one that forms a complete circle. Scott McCoy, in his brilliant book, Your Voice, An Inside View, reminds us that it resembles a signet ring. Think about, the big rings maybe. I told Gary and Scott beforehand that this title of the slide almost bears a Lord of the Rings reference. So let's just go with that and think about one of those big rings that those characters wear. That's maybe a bit thicker at one side than the other, and that would be the frontal anterior side of the cricoid cartilage. That would be larger. It's attached to the thyroid. Not only is there a membrane there, but it's also a type of joint called a synovial. Synovial joints are found elsewhere in the body as well, and they really allow for lots of rocking and turning that's very important for our ability to phonate. The arytenoid cartilages, to really get an eye on those, you have to look inside the larynx, and this is not quite the right, manipulative for this, but they're here on the underside. And if you looked really close, you could see how the top kind of go off to the side, and that's the reason for my mention of an elf hat. Okay, these are the posterior point of attachment for the vocal cords. So these vocal cords, vocal folds, as we'll talk about in a few minutes, so it's fine to say both, attach in the front at the commissure like a V. Okay, and then they attach in the posterior, the rear, at the arytenoid cartilage. And these are also, the arytenoids are also the attachment points for the muscles that open the glottis, which is open the vocal folds, okay, as we'll find out here more in just a moment, okay? The vocal folds, this is the current favored term. Vocal cords is still okay, but just as long as it's C-O-R-D-S and not C-H-O-R-D-S. There's too much confusion in voice research over the last several decades. Now that we're very much in the scientific voice research era, gratefully so, it's really important to have a term that is really representative of the most current thing that we know, and that's that we're talking about folds. We're talking about structures that actually vibrate like this. Some of you have maybe seen, and I will say that I've used it in my own teaching, the idea of like, kind of like fins or like a mermaid tail. You see the chords kind of oscillating, and here I go saying chords. It's in our brains, right? We've been hearing vocal cords for years. But the idea of folds that oscillate like this. Now down here, that's the air coming up from the trachea, okay? That as that goes through and as they vibrate, they're actually vibrating, oscillating like this. And the vertical phase, as you can see, how they touch on the way up is something really important. The folds themselves are actually quite small, about 18 millimeters long in women and about 23 millimeters long in the average male, but only 12 to 15 millimeters of that space is actually available for vibration. We have the attachment at the commissure in the front, we have the arytenoid attachment at the posterior, and they just don't completely oscillate or vibrate completely from end to end, okay? Folds of tissue rather than chords like guitar strings. Okay, there are certain parallels to guitar strings that we'll be talking about, but this fold idea is really, really important. Okay, so we're going to take a moment here, and I'm going to say thank you to University of Washington, where this YouTube video came from. I think sharing sound is not incredibly important for this one, but if you can hear the sound, that's an added bonus. I just want us to see as I play here the folds acting on each other. So as we look down from above, this is what a laryngoscope video stroboscopy would see. Okay, when air is coming through, the cords are apart. When singing tone is going on, they are together. This is a relatively high tone, so you can see thin part of the chords oscillating with each other. This is a nice, healthy larynx for all that I can say as a non-medical practitioner. There's I'll just throw in that one of our most important ideals as teachers is that we not try to diagnose, that we stay in our lane when it comes to any disorder of the larynx or any otherwise. We're a much better idea is to pass that to a speech language pathologist or even a laryngologist with a special fascination for singing. So as you see this happen, now we're hearing some lower notes, if you can hear this. The chords are shorter and thicker, which I'll keep coming back to, but I just wanted you to go back. I just wanted to show us that for a moment. So I'm just going to take us back to the presentation here. Sorry for my change of screen. All right, now we're going to go into the idea of the fact that we have true vocal folds and we have false vocal folds. Back to Luther, okay? As we go up from the trachea, the vocal folds are right here. There's a spot in here called the ventricle where actually some of the really important mucus that helps bathe the vocal folds is found. And then above we have something called the vestibular folds. And I wrote ventricular. We have a ventricle and ventricular folds, which are not actually the vocal folds themselves, and in most cases don't completely close, but you can see them drawing closer to each other in that video. Okay, the epiglottis, like we said before, is a bit of a gatekeeper.
Ryan, I think you bumped your microphone and I'm not hearing anything now. Heard a bit of a scratching, like a microphone bump.
Is it better now?
Oh, there you are.
I knocked my headphone cord out. My apologies.
You're not the first person in the world to do that.
Here we go.
Okay. It
So
was
we
right
have
as you
a
were changing to the new slide.
yes. Oh, okay, good. Well, I'm glad it didn't take too much of the talking away. We basically, when we talk about the vocal fold, we're talking about a structure that has a cover and has a body. The cover similarly termed to the exterior layer of our skin. We have the epithelium or the epithelial tissue. And underneath, we have what's called the lamina propria and the actual thyroid-rytenoid muscle, which is the vocalis. Maybe some of you who've taken some time in voice pedagogy already have heard that term used. But here's our experiment.
Again, if your intent was to be sharing screen, we lost that now.
Oh,
As you were shifting the microphone, I think. So
okay, well, let's fix that. Thank you all for your patience with
thank you
all
for
of
your
these
understanding
things.
as I chime in.
That is totally fine. Are we back to in good shape?
I hear you and I see your screen, I think. Yes.
Fantastic.
Oh, that's a great chart with the epithelium right there. Okay.
Yes, it's a
Thank
pictures.
you.
That pictures do it for a lot of us. If any of you are hanging out today, really hoping that we're going to see some gross pictures later of all kinds of terrible things that can happen to your vocal folds, that'll have to be another day. I decided to not go into those things, although having some experience in the medical arena myself, I like those pictures just as much, maybe more than some, but we're going to keep it. We're going to keep it, looking at the good healthy larynx today. Okay. In any case, we have a cover, an epithelium, and we have a body of the vocal fold, the lamina propria, which has 3 layers, and then the actual thyroid-rytenoid muscle. Okay. So take your hand here and just sort of grab the skin on the back of your hand. You notice that this moves pretty easily. Okay, you can kind of slide it back and forth. That's something akin to what we have going on with the epithelium. Okay, and then if you turn your hand over and kind of grab the heel of your hand here, just open, you'll feel more of what kind of the lamina propria is. It's a bit of a cushion that helps absorb force. Because let's face it, those folds are hitting against each other, and in extreme cases that can cause some problems. We even have a term called phonotrauma, right? The hitting of those chords together that can create some not nice things. So let's do a further experiment. Take your index finger, join it with your thumb, and now feel the heel of your hand. Join your middle finger to your thumb, then your ring finger to your thumb, and finally to your pinky to your thumb. You'll notice that that heel of hand tissue gets stronger and thicker and denser. And we also talk about viscosity, resistance to flow, just sort of, we can think about a liquid. Water is not viscous, it's lower viscosity. Pancake syrup has higher viscosity, okay? When we're talking about these 3 levels of lamina propria, we have a superficial, an intermediate, and a deep layer. So think about your favorite gelatin dessert. I said I was Lutheran, so that means I'm descendant of lots of folks from the Midwest, North Dakota and Minnesota to be exact. So let's think about those gelatin salads, okay? So the outside layer, the superficial lamina propria, that gelatin is not quite set, okay? The middle layer, it's starting to set, but it also has the vocal ligament runs through this intermediate layer. So maybe this is one of those jello salads that has some fruit added, or maybe some other sort of thing. And so it's maybe a little slower to set. And then that lower level, we have a fully set piece of gelatin, if that makes sense. Okay, vocalis or thyroid-rytenoid runs below those things. Okay, 4 things are required for phonation, which again is creation of sound. We have to draw the folds together to close the glottis. The glottis is the space in between the folds when it's open. Okay, epiglottis above the glottis. Okay, a lot of medical term that's coming in for you today. Okay, so the vocal folds need to be drawn together, which closes the glottis. This is a process called adduction. There has to be a way to pull them apart to stop phonation and help air go through, and that's called abduction. Okay, some of you maybe have done these machines at the gym where you're bringing your knees closer together, and that's adducting, and you pull away, that's abducting, right? Okay, we also have to have a way to lengthen and shorten the vocal cords, because when we have long, thin chords, we have higher pitches. When we have short, thicker chords, we have lower pitches. You probably won't be able to hear this, but it's a very low twang, okay? If I stretch it out, the pitch moves up, and the longer and thinner a rubber band or guitar string or vocal fold length goes, the higher the pitch, okay? Now, we have muscles of the larynx that are all very important, okay? The two main muscles that we talk about in voice instruction when we're talking about registration are the thyroarytenoid, TA, which is, it's represented in kind of two layers here. They call one vocalis and one muscularis. If you think about like the muscle part of it and the actual vocal part of it, that's, we're talking about very small structures here. So, just in this extreme detail of a scientific picture, can you see this? And then we have the cricothyroid muscle, okay, that are, on the two sides here. Okay, so thyroarytenoid, TA, is in charge in mode 1, modal voice, chest voice. We call that thyroarytenoid or TA dominant sound. When it comes to mode 2, head voice, falsetto, we're talking about a cricothyroid or CT dominant sound. Okay, the muscles that are also involved here, we have a set of lateral cricoarytenoid muscles. We have interarytenoid muscles. We have things that are responsible for the actual opening and closing of the glottis, right? There's these, all of these muscles are also, as I'll mention here, what's called intrinsic. These are muscles inside the larynx. I'm consistently sharing with my students the fact that it's important for us to know about these things so we can have a physiological and scientific background for what we're doing, but also with the caveat that these are muscles that you cannot knowingly tell one to work and one not to work, or flex, or something like that. So this is really, more of a directed process that goes on between the muscles and airflow. Okay, so as we go outside of the intrinsic part of the larynx, we use the word extrinsic, which is outside of the larynx. Okay, we're talking about mostly muscles of the neck, right? Think about, or bring Luther back here, the muscles that are around the outside of the larynx, right? You see some vasculature that's here, some arteries and things like that. It's just as important as anywhere else in the body for arteries to carry oxygenated blood and veins to carry deoxygenated blood, right? So we have there's lots of veins and arteries and things like that. That's definitely not the Vocal Anatomy 103 version, but there are so many really amazing resources for inquiring minds. Certainly one here, should you want to further pursue this study, I would welcome direct questions, emails. I'm happy to help share suggestions. But when we're talking about extrinsic outside muscles on the larynx, we have some muscles that are involved mainly with swallowing. Okay, let's talk for just a second here outside of the voice world and talk about what happens when you swallow. Okay, so put your hands on your larynx again. Say hello to that thyrohyoid gap for a second. Get reacquainted here. Okay, and now put your thumb and forefinger on the front of your thyroid cartilage and swallow. You notice that there's an elevation and then there's a depression, right? Epiglottis closes over the trachea. Saliva that was in your mouth has now gone down your esophagus towards your stomach. Okay, So I notice here I'm missing a few marks. I'll have to go back and edit that. But we have constrictor muscles. And they're, as you can imagine, those are mainly responsible for helping us swallow. Now, constrict doesn't sound like an incredibly positive thing, does it, when it comes to singing? And it would be true that we have to be careful that our constrictor muscles, that can be muscles of the neck, muscles of the shoulder, several muscles I'll, talk about down here as laryngeal depressors, they root all the way back to your scapulae in the back. We have muscles that attach down in the upper chest, your sternocleidomastoid that runs down the side of your neck. All of these muscles, if they're too constricted, can really impede our vocal process. So we have to be aware of them. And then the idea of doing nothing feels like doing something when it comes to singing, right? Releasing, getting rid of one of my very influential teachers who I'm eternally grateful to is Dr. Kari Reagan. And she uses the word recruitment of other muscles that we don't need to use when it comes to singing. We don't need to get them involved because they're just going to make things more complicated. But in any case, we have muscles that elevate the larynx, laryngeal elevator. Now I'm going to show you some things like, I'll use the word hyoglossus. Okay, glossus is the medical word for tongue. So we had the hyoid bone. Now we're going to talk about the hyoglossus, a muscle that attaches the hyoid bone to that flows from the hyoid bone into the tongue, where it starts, where it inserts from the hyoid bone into the glossus, into the tongue. The thyrohyoid muscle that starts at the thyroid and inserts into the hyoid bone. Okay. Digastric is you think about, you've heard the word gastric when it pertains to stomach, right? Digastric, there are two bellies of this muscle that, that are, involved you're actually in the region of that digastric muscle when you do that little massage that I had you do earlier. Okay, and I'm calling your attention to these not because there's going to be a quiz, there certainly isn't, but just to show you how many more muscles there are that are devoted to lifting the larynx than there are to depressing the larynx. And I will say to you right now that sternothyroid means from the sternum to the thyroid. Sternohyoid means all the way from the sternum all the way to the hyoid bone. And omohyoid pertains of an attachment that runs from the scapula, like I mentioned a few moments ago, all the way through its, sort of circuitous pathway, to use that term, all the way to the larynx. So these are things that pull down on the larynx, but many more things pull up on the larynx. And when it comes to ideal laryngeal position, we want, for most styles of music, a neutral larynx position. It's a little lower for classical singing traditionally than it is for contemporary vocal styles, or one example might be music theater singing, a brighter, twangier, more forward, if you want to use that language sound. But neutral in the larynx is what's important. That means we don't want to be pulling, sort of mechanically pulling down with any of those depressors, right? I'm thin enough in the neck here that if I do something terrible and go, you can grip real hard on your teeth, and a lot of those muscles, mainly the scalenes here, if you can see my pointer, those are really getting involved, and that comes with lots of tension in the jaw muscles, the stylohyoid, the mylohyoid. You're getting, sternocleidomastoid involvement, and it just, the end result is a whole lot of tension. Okay. As we move into the way we start and the way we stop the vocal tone, I wanted to spend a few minutes talking about this thing. So when we see the word glottal, okay, it's one of three main ways to start and stop the vocal tone. Okay, an extreme glottal onset, or starting of the tone, would be much akin to kind of a grunt. Okay, now I invite you to try this to yourself. I do caution you to be careful. I've demonstrated this a number of times, so I'm confident that I won't injure myself when I do this. But think about the idea of a grunt beginning. Like right? Something, what we're talking about when we have a glottal onset is that we have a closed glottis. We have closed vocal folds when you begin the tone, okay? If you want to think of a more gentle glottal, you just think about lots of times in American English. You notice I didn't say American English. I said American English. I put a glottal stop at the beginning of both of those words, which it's natural. If that was traumatic to the voice, most speakers of English and German would have vocal injuries because we do it all the time, right? Moving on to the second version, aspirate. Okay, this is best summarized by the idea that there's an H before ha, ha, ha. And if you do a really extreme aspirate, right, barely starts the tone. Okay, this can be really contributing to something we really don't want to have happen, which is a phenomenon called MTD, or muscular or muscle tension dysphonia. Dysphonia means sound problem, an inefficacy in sound, right? And that's something that would one, develop MTD, that would need the therapy of a speech language, pathology professional, perhaps a laryngologist. And we like to, to form a triad of voice teacher, SLP, laryngologist to, assess and address all the needs of a singer. But the likelihood that you will need those advanced interventions is less if you work on a more balanced onset. I frequently have my students say, oh, I see, right? Not, oh, I see, and not, oh, I see, but, oh, I see, right? That's more of a balanced onset, okay? Or a balanced onset. You can even, when you separate your words, a balanced onset, right? This is not the greatest microphone. This is the indwelling microphone in my computer. We've all discovered some great microphone technology in the last year. If I were to be really showing you the, the spectrograph and everything like that, you could see those designations a little more clearly. But we also have to talk about offset, how we stop the tone. If we stop the tone by squishing the chords together, say that we're going along, oh, and we sort of just like squeeze the chords together, that's a glottal offset. If we go, oh, and basically blow an H through that, oh, right? You might have been able to hear it kind of peter out, right? But if we have a balanced offset, we can go from, oh. What I tell my students a lot is that it's the idea of just, it's like stopping the supply. It's like, cutting off the air supply to the voice. It's not pushing more through. The notion of taking a breath in, actually taking an inspiratory gesture, also comes up sometimes. That can create, oh, right? Some sort of hiccup looking thing. So one has to be careful with that. But in any case, oh, just sort of removing the air energy can help us with the balanced offset. Okay, too much air through the chords, excess air is going to produce a breathy tone, right? If we have not enough efficient fold closure, we've got air coming up through, we've got inefficient closure, we get a breathy tone. If we have, and that's also not enough subglottic pressure. Some pressure coming up on below the glottis is good, right? If we have too much subglottic pressure and too hard of a fold closure, not enough gets through and we have a pressed or forced tone, pressed or forced phonation. So the idea of a flow phonation where we have steadily oscillating vocal folds is ideal, okay? Before we near our end today, I want to share with you for just a moment, I'm gonna come out and stop my screen share of my presentation so I can let you watch a few things. So the idea of semi-occluded vocal tract exercises, or SOVTs, this is something that I alluded to in my vocal health presentation, and I understand Scott will be talking about very quickly as well. It's a very important set of gestures. I believe there are 13 or so individual postures now that we've come up with that basically are therapeutic to the voice, because instead of opening everything up and saying, ah, ah, we're taking that tone right from the larynx and out the mouth. We're going to interrupt that somehow by humming maybe an M, an N as in Nancy, an NG as in hung. I'll just say that I really like the NG because you can think about an ah position while you do it. You're just using the back structures here to occlude off the space of the air coming out of your mouth. So probably one of the most famous SOVTs is straw phonation, okay? I have 2 straws here. These are just run-of-the-mill drinking straws. I think I got them both at Target. This one is a bendy one. If you're going to do SOVTs, you want to keep the bend out of there because that's going to create another barrier for us. But depending on the voice, you might want to try different straws. But the idea is to inside think ah, close your lips around it like an O, okay? Now, I don't want you to think of like blowing air through a clarinet. So it's not like, right? You're singing through a straw, right? You can sing your repertoire on a neutral vowel through a straw. You can do so many things with this, right? Higher voices sometimes like a smaller straw better. The material of the straw matters little. The length of the straw matters little. The diameter of the straw matters more, okay? So a smaller straw, you have to more closely concentrate your airflow. Higher voices with a larger straw may feel like they're kind of going, oh, I'm kind of blowing this overly oscuro, dark type of thing, and might like a smaller straw. I'm a baritone myself, so a medium male voice. I'm acquainted with a number of coloratura sopranos and even some male singers who have found success in even like a coffee stirring straw. Now, for me, I notice lots of facial tension when I try to go around that straw. So I think it's probably quite counterproductive. So for me, I make others aware of it, but I don't use the coffee straw myself. So this is just an example of a really great comparison. Would maybe be on your next trip to Starbucks. You know, grab one of the regular straws and one of the larger straws for if you get the big drink, and compare with some of this straw phonation. You're not just like palpating your larynx. You're not going to hurt yourself. So please, I invite you to try these things. Some things to check. Make sure the air is not escaping through your nose. If the air sound changes when you plug your nose, right? We don't want it to change, right? Okay. Keep track of your tongue position, position, relaxed in the bottom of your mouth. Another thing that we can do is blow some bubbles in some water. This is 3/8, I believe, 3/8 inch surgical tubing. You can find it where fish tanks and other supplies are sold. You can also get it through medical supply companies. But this is a 3/8 flexible tube, okay? And we're going to do this for what we call water bubbling, okay? So I left a little in my water bottle. I'll kind of, give some, I guess, some endorsements to some wonderful Seattle and other companies while I do this, because I've covered my water bottle with them. But basically, you want to put your straw down an inch or two into your water, okay? The further down you go, the more resistance. If you're barely into your water, you're not going to get the right idea here, but you can blow bubbles by themselves. Or you can even phonate. And one of my favorite things to do through the straw is the beginning of the Star Spangled Banner. So I might go. That's also a really great way to hear how the bubbles get more intense and they get faster as you get higher, right? Way to just kind of take a time out and illustrate this. Think about how fast you can pound one figure on your palm or on the table, right? You can, if you're fast, you can get it, maybe 10 times per second. I don't know, something like that. But if you think about doubling it to your first and second finger, it gets faster. You start using your third finger, you start using your all four fingers, and it gets even faster. Right? The higher we go with notes, that intensified air, the longer, thinner folds, and the frequency, the vibration measured in hertz, increases and increases and increases. Okay, and that's evidenced by back to our rubber band. High notes, long and thin chords, low notes, shorter and thicker chords, right? But I won't shoot this at the screen, I promise. But remember, we're talking about this. We're talking about that commissure at the anterior and the posterior attachment with the arytenoids. Okay. One more fun device. This is called a flow ball. Okay. We're talking about mostly air here, right? When we talk about flow. Okay, the flow ball can be used for a lot of things, like training your breath. That belonged in the respiratory lecture for sure. But maybe things like try to hold, take a nice round breath, appoggio, leaning thoracic on abdominal, like you've probably been told before. And then, think about leaving the ball, keeping the ball elevated for 8 counts, Right? That's about as long as any vocal phrase you're going to have to sing. Okay, you can also think about intensifying your air. Right? Okay. And if you get the flow ball, that's the name of this product, it comes with a great little pamphlet that makes it look like maybe people even use this for fun, like a little throw it and catch it game, where you can have a friend with another flow ball. Although I guess maybe now with our, sharing air, this might not be, what it once was. But I'm just going to give a quick nod, and I'll give some credit here, and further credit in a moment to one of my very wonderful teacher, Dr. Kari Reagan. But in her book, A Systematic Approach to Voice, The Art of Studio Application, she uses a term called phonate. Okay, and that's the combination of the flow ball and making actual vocal tone. Right? Subtle increases of height of the ball as pitch goes up. Okay, you can also see that it doesn't stay, the ball turns this way. Sometimes it turns a little bit this way, goes up and down a little bit. There's ever-changing variance in the pressure while we sing, right? So efficient airflow and the actual muscles and everything that we've talked about in the vocal folds work together to keep the vocal folds oscillating. There's for another day, a very fascinating line of thinking from, the myoaerodynamic model where it's a combination of muscle and air that creates vocal fold oscillation and keeps it going. That evolved into what they call a one mass model, where like they think that the air pressure just above the folds helps in keeping the folds vibrating. And now I'm told that the University of Iowa, which is one of our preeminent voice research institutions, has now come up with up to 16 masses that they're talking about helping in starting and continuing vocal fold oscillation. But all of this plays together to create our vocal process. As we move to the final slide here, I just wanted to share once again that the larynx's main job is to protect the airway. It's very remarkably capable of creating the sound required for us to communicate, to speak, to sing, to yell. Maybe we shouldn't, but sometimes we have to whisper. Another nod back, if you didn't have a chance to catch the vocal health lecture, go back and listen to some of the things that we talked about whispering. One can whisper, effectively, efficiently. You can just take the volume down, but one shouldn't whisper like this, especially when your voice is hoarse, because you're actually putting more strain on your voice. Okay, and another overarching theme for today is when it comes to the actual artistic part of being a singer, having this scientific and physiological knowledge is important for giving us a framework, that's something that can be based on facts, that what we know now, right? Obviously, we have an artistic side. We can't choose to flex our thyroarytenoid muscle like we can a bicep or a tricep or a quadricep. But we can have knowledge and awareness of what's going on, and knowing the relationship between airflow and the folds themselves, what muscles are involved, and what we can maybe do to avoid recruitment of things that aren't going to be helpful is really vital to our ability to sing most efficiently. I do want to again mention Dr. Kari Reagan's book. Stop my screen share here so you can see. Give thanks to past pedagogues that predated our generation and the generations before us. Manuel Garcia in the 19th century, who was one of the first sort of scientifically able voice researchers that gave us some ideas on onset and offset of the voice. William Bernard, who was at the University of Southern California for years and years and years, and whose book Singing the Mechanism and the Technique was the more or less the Bible of vocal teaching for quite some time. Johan Sundberg, Swedish voice scientist. Dr. Ingo Tietze. I'm just giving very brief summary here, certainly not befitting their monumental stature in our study of voice science, but these are just some of the names that helped us be able to be where we are today. And from me, I would like to thank Gary Cannon and Scott Kovacs for having the Emerald Choral Academy, so I can be with you today to share this topic that I'm very, very passionate about. And also, I would like to take this time to thank all of you. Before we go, I'm happy to take some questions, but I'm so appreciative of the opportunity to share some of my passion and some of the knowledge that I've acquired. Much thanks to these folks that I've mentioned to you in the last minute or so. And I just wish you happy singing and happy teaching, and maybe more importantly, happy larynxes or larynges as we go along.
I was afraid you were going to say like happy larynxing,
Oh.
to turn it into a verb of some kind. Hold on.
I might have made up a term or two over the last hour. So if there are any, real, science or medical terminology inclined people, and I unintentionally coined a term incorrectly today, you can let me know.
I've had rehearsals where some singers have said, Gary, I really hope some of our foreign, non-native English speakers understand which words you're making up and which ones are real words. So but we do have a couple of questions.
Yes.
And they're both fantastic ones. One regarding the SOVT exercises.
Okay.
Are those a kind of strength training for the muscles, or are they to train yourself how to avoid tension, kind of relaxing training of sorts, or is there?
I think that's a really great question, and it's worded perfectly. It almost has the answer in the question. Is that SOVTs are very therapeutic for the folds themselves because they encourage efficient closure. You know, you can overblow and make an aspirate, through your SOVT, or you can over constrict, and the sound can be quite pressed or forced, or we can find that you might also find that I can speak only for the male and specifically baritone voice. If you measure pitches, we're used to, not having to switch over to falsetto until, for most of us who aren't extremely low voices, until at least past middle C, maybe, E or F, or even further in the higher tenor. You might find that your voice wants to swap over, swap registers a lot sooner when you're doing SOVTs, and that's okay. So it's really to help us feel what not so tense fold contact feels like, and also to encourage that healthy closure. Great question.
So I'm rephrasing to make sure
Yeah,
I even understand it too.
sure.
You're saying that it's to allow the singer to understand better the sensation of the relaxed phonation. Would that be an accurate
It
summation?
would be, and you're giving your folds and the larynx the added benefit of having some of its energy directed back toward it instead of all of the energy directing out. I think I might have said this perhaps during vocal health lecture, that if you think about, like, a positive and a negative charged particle, think back to your chemistry class. If we're singing out, everything's positive, right? We're pushing lots of energy out. If we do an SOVT and we make a partial occlusion, we're allowing some of that sort of negative air, flow to go back towards the chords, and really giving them more, to be very informal, more bang for the buck, right? And we talk about our chords, folds banging together. That may not be such a good thing, but more bang for your buck, right?
I think I tend to talk about it in terms of increasing glottal efficiency.
Right.
As a way to describe that, increasing glottal efficiency, because there's a more equal amount, that the air pressure is supraglottal and subglottal is more equal. So there's a greater efficiency there, which means that there's, now I'm going to be informal, a less violent interaction at the vocal folds, and it tends to be more efficient, and there's less tension from the subsystems of the voice trying to hold on to everything. So it's just sort of, it's a more relaxed posture for the muscles because there's an increased efficiency at the glottal level.
And there's more flow phonation, like we were talking about, which is great.
Yeah, right.
Yeah. And I'll just say again, you can't hurt yourself doing SOVTs. You really can't. You can't hurt yourself with a gentle palpation of your larynx. Get to know this structure that you are asking to do a whole lot when you sing. So
Now I'm just waiting for somebody in the YouTube to quote you on that and say, "Challenge accepted." See what they can do.
I cannot be responsible for overstep beyond that.
I remind that in a few weeks, Scott Kovacs, who's right here on this window, will be teaching at greater length on SOVTs. But it was great to bring that in now, because
absolutely. And Ryan, since we were talking about the flow ball, do you know about the Dr. Vox?
I do. I don't have one, but that's much more reliable than what I got going on here. I'm sitting here trying not to spill on, Dr. McCoy.
Yeah, this is a great way not to get water all over your piano when you're teaching.
Absolutely, I'm with
great
you.
device.
Yeah, that's great.
We had one other question, and that is, how would certain medications potentially affect the vocal folds adversely? And they may be medications one needs, and so I would add to that question, how does one adjust technique in order to accommodate the potential necessary medications? That may be a very deep question beyond
I mean, I think it's a great one. I mean, I think that, I said early on that I really tried to strive hard to keep keep us 103 today. When it comes to what you're talking about, medications that might adversely affect the voice, they might do that because of things like drying. We count on the vocal folds to be bathed in mucus. I know that's a wonderful idea. We want them to be moist and supple and able to move. And if they are dehydrated and dry and inflamed, they're not going to do their job. So medications that may dry out the vocal folds would be something to be aware of. And I'll remind us again. I think I said something in the vocal health lecture about only about 30% of the fluid that we intake gets down to the fold levels. So lots and lots of hydration if you're taking medications that may dry your folds out. One thing that we didn't talk about that goes with some things that can evolve into vocal injury, things that might come from something like acid reflux. If you're a singer and you have to take medication for acid reflux to keep the acid from coming up and irritating your vocal folds, you might have things that you need to do to counteract that as well. You might need to say that you're taking an acid reducer oral pill and you're dairy sensitive and one has to know your own body's needs and work. I think it's important to say, and work with your physician. Many of your general physicians, every general physician I've ever had in my life as a singer has been so helpful if they can be personally and willing to refer and find answers for me if I'm wondering, well, how does this affect my singing? If I'm going to take this or I'm going to do this, what do I need to be careful of? And there's great research out there, lots of intersection of medicine and voice. Dr. Robert Thayer Sataloff, who is based in Philadelphia, is still contributing tons to the idea, from the medical side. Dr. Sataloff is an incredible individual. He has a DMA, a PhD, I think, an MD, all kinds of things, and he comes just putting all of or have doctorates or trying to have doctorates.
That's just showing off.
Just way too much. But see Dr. Sataloff's things. They're wonderful articles in the Nats journals that come out every other month. They dedicated a column to medications in the voice several times. Dr. Kari Reagan has some articles on medication in the voice. We're really, really fortunate that lots of people are doing great research right now when it comes to voice science and the medical intersection. So, and I'm happy to share individual suggestions with anybody as well.
Yeah, so one thing then in particular, you're talking about the dehydration. Even if your doctor doesn't know a lot about the voice, you can simply ask them, will this medication have a tendency to dehydrate me? And there's an answer right there.
So I dropped into the chat both the ECA second semester classes that include Ryan's vocal emergencies and my everyday vocal health. And there's a slide deck for both of those that has a lot of references in both slide decks, particularly with regard, I think I did in mine on everyday vocal health. We talked the very concept that Ryan was talking about, getting to know your voice with regard to how you interact with the environment, including things like medications, as a first step to knowing how to manage medication-related changes to the voice.
I think I alluded to it in my vocal emergencies lecture, but just something else that comes to mind is, we think about things that we, medications we take when we're in pain, analgesics, the possibility for ibuprofen to be not so great for the voice if we have been doing a lot of singing, and there might be little micro abrasion, or might even be a little bit of capillary damage. Something like ibuprofen can be not as good of a selection as acetaminophen, which is Tylenol. But you need to work with your doctor to make sure that you shouldn't be taking naproxen instead. Or you really need to make sure that you are adequately doing your research when it comes to being in primal vocal shape. I'm gonna just jump in because somebody asked about the intrinsic muscles of the larynx. And I think I know something that I left out. And I'm going to show you in Dr. McCoy's book something I was talking about. So the two main muscles that we're talking about, vocal cords or vocal.
We've lost your audio again, Ryan.
I knocked it out again. I'm back.
As you were
Sorry.
reaching. That's all right.
Okay. So we were talking about the thyroarytenoid. Those are here. Okay. The cricothyroid muscle, which are mode 2, in your head voice, the CT is dominant. Okay. They're there. Okay. You have what's called the lateral cricoarytenoid muscles. Okay. It's here on a double pointer. They're on the sides here. Those muscles in combination with the interarytenoid, which runs the top here, those are responsible for closure. And the posterior cricoarytenoid, PCA, which is along the top here, is helpful in opening, okay, or in abduction. And the other ones are responsible for adduction. That's a really great question, and I'm really glad you asked it, because we're expecting muscles to do a thing. And, when we have all of these muscles contained, within this walnut or pecan shaped sized structure, we're talking about some pretty small things here.
Yeah, thank you for reviewing that. It brings us
Sure.
back to the whole point of vocal anatomy, the
Yes.
real reason we're here. And thank you especially, Ryan, for also incorporating some practical aspects into this, like the SOVT,
Certainly.
things that we can do to learn how to use the larynx effectively. Thank you to all of our participants. There's some great questions for all of your contributions. The next offering of the Emerald Choral Academy will take place on Wednesday, October 20th in the evening, Pacific time. And that will be a very special panel led by composer and conductor Giselle Wires. We'll discuss expressing text in music, not just from the point of view of a composer doing so, but how one interprets it as a performer. It's a special conversation. We'll discuss, among other pieces, one of Giselle's more recent large-scale works called "And All Shall Be Well." And so we'll have the composer for that piece, the conductor of the premiere, that's me, the person who helped the composer to create the libretto, and the translator of several of the poems. So we will all discuss from our different perspectives this aspect of expressing text in music. And we hope you'll be able to all attend that. All of us at the Emerald Academy are very grateful for the enthusiasm of you, our audiences and supporters. As this Emerald Choral Academy continues, hooray, hooray, you can again help to support these efforts by donating at emeraldensemble.org. You can also let us know of topics that you would like to see discussed in the future. We've had a couple of ideas come out of it just in today's discussion too. So in the meantime, I'm Gary Cannon here with Scott Kovacs, our executive director, and with Ryan Bede. On behalf of all of the Emerald Ensemble, I wish you good physical, mental, and musical health. Thank you. Scene.
And scene.
As it were.
Yeah,
Thank you again all for being here, attendees. Thanks. Yes, and thank you, Ryan. That's magnificent. Holy moly, I learned a whole lot.
Oh, good.
I should stop recording. One of the things I should
Yeah,
learn.
I was just about to say, but I was going to keep